Retina Rounds, podcast number 23. Today, Retina Rounds is excited to welcome Dr. Devinder Chauhan, an Australian vitreoretinal specialist, innovator, and founder and CEO of Macuject. Dr. Chauhan is pioneering the use of artificial intelligence to support imaging-based clinical decision-making in retinal disease. We'll explore how these tools can be integrated into clinic workflows to help tailor treatment intervals, refine diagnoses, and hopefully improve patient outcomes. Let's check it out.
Well, welcome to the Retina Rounds podcast Giants and Retina series. We're honored to have an international guest here during the American Society of Retina Specialists meeting in Los Angeles, Dr. Devinder Chauhan from Melbourne, who has a fascinating background and is a real innovator in our field. So Devinder, welcome.
Thank you. Thanks, Steve. It's good to be here.
It's really great to have you. Tell us how you came to be an ophthalmologist and a doctor.
Okay, when I was at school, I saw a careers advisor who wasn't a very good careers advisor, and this was in the early 80s. And she said to me, "What do you want to do?" And I said, "I want to do maths." And she said to me, "So do you want to be a maths teacher?" And I said, "No." She said, "Well, why do you want to do maths then?" And so I didn't. And I've sort of regretted that because everyone I knew who retired at 40 did maths and went through the 80s in London. This is in London. And anyway, so I kept going. And my mum, when I was literally from before I was born, wanted me to be a doctor. I'm an only child son. But she kept talking about it. And when I was 12, I said, "Just stop, please don't mention it again." So she didn't. And then when it came to applying for university, I was in a position where I didn't really know what to do because the careers teacher hadn't helped. And I thought I'd like knowing how the body works. So I thought I'd do medicine. And that's how I ended up doing medicine. And once I was doing medicine, the first 2 years, the preclinical were really, really interesting. I loved it. And then the 3 clinical years were good, but I got to a point where I just wanted to know why we were doing stuff, what the reason for different things was. And I was somewhat frustrated by the answers that were along the lines of, there's been a study to show that this works better than treatment A works better than treatment B. I wanted to understand the basics of it. So I went into medicine, did that, and then ended up doing an MD, which in the UK is an additional higher degree, and did that with John Marshall. And the best part of that was the fact that just through, not through the maths, but through conceptual thinking and doing some experiments with OCT, we had, I think, the first OCT outside of Tufts at the time, doing experiments and thinking about what's driving and generating these images, ended up with the point where I sat down with John and I said, "I just don't get this thing, and it doesn't make sense because I'm expecting this and it's not doing that." And I got to the point where, and this is slightly self-aggrandizing, but I got to the point of wave-particle duality, and it's like, oh, no one's really got beyond that. They've all done it with maths, but I got to that conceptual point, and that was cool. The ophthalmology part was driven by a combination of wanting to do medicine because it was interesting and it used your mind, but being frustrated when I did medicine as an intern or a houseman, where you didn't actually do anything. You'd walk in on a Monday morning, someone's potassium was 2.8, which was low. You diagnose it, fix it, they leave on Friday and they've got a potassium of 4.3, which is fine. You've saved that person's life, but I didn't actually do anything with my hands. And then with surgery, which was the second 6 months, we would, at that time there were no CT scans and MRIs, we would go on ward rounds where someone would be sitting up, have an examination, and the answer was just open them up and see. So everything is done with the hands, but very little thinking. I liked the way that ophthalmology was both of those. And that's where, because you got to think and do, and that was the best part.
So you grew up in London, Greater London. Were your parents born in Britain or did they emigrate?
No, they emigrated to London in 1963. I was born in 65. So I was the son of two immigrants. I literally wouldn't have been born. I'm an only child because my mum had had lots of miscarriages before me, late miscarriages. I wouldn't have been born if it wasn't for the NHS in the UK, where as a recent immigrant, my mum was diagnosed as having issues with late pregnancy. So she was kept in bed for the last 3 months of her pregnancy.
In hospital?
A significant part of that was in hospital.
Wow.
Free at the point of care. That was because of the National Health Service, so the taxpayer paid for it. I like to think I gave back later. But that was a significant part of me being, I wouldn't be here if it wasn't for that.
And what sort of work did your father do?
So my dad was a teacher in India, got to England in 63, qualifications not recognised, worked as a labourer. His last job in the UK was, before he retired, was, as you probably walked past him, the station master at Heathrow Airport, underground station. So he stayed there. My mum used to work in a windscreen wiper factory. So again, that the free education and everything just meant I could do what I could do. Got to do medicine. I went to Guy's, pretty well respected medical school. Got through all of that essentially because of the social network that happened because of the way that the politics worked.
Do you spend time thinking about the sacrifices your parents made? Erudite, super intelligent people emigrated to a land that didn't recognize their education, and they became laborers when they were actually intellectuals. And they did that, and here you are. I mean, does that resonate with you frequently?
It does. My mum they weren't particularly intellectuals. My dad was a professional, he was a teacher. But yeah, it does. It's one of those things where I'm not going to repeat the whole immigrant child story.
Sure, but
it's a very common one. But essentially, I ended up getting where I am because they did make sacrifices, didn't go on holiday, didn't do a whole bunch of things. But in a way, that's the natural, very common first generation immigrant thing to do. It's that actually very middle class, deferred gratification, deferred by a generation, not just by a few years that they did.
So you got to Guy's, you chose ophthalmology, and where did you do your ophthalmology training?
So my first job was in Welwyn Garden City, which is outside of London, and with a few consultants, one of whom was John Bolger, very well known for his cataract surgery. Did well there, learnt how to use a slit lamp and etc. And recognise cells and flare, and was taught by other people around me, Lawrence Whitefield being one of them. And then when we moved, I went to the next job. That was at Royal London Hospital, and that was cool because got to work with a guy called Ivor Levy, who was a really good neuro-ophthalmologist, and Alan Musham. So I got to do more and more, and then after that, ended up at St Thomas's Hospital to do a junior training in the UK called an SHO, which you do, and then that's followed by a registrar training. The training in the UK at the time was very long, and there were no obvious fixed periods of times that you did it, so you had to keep moving, and it was between SHO and registrar, like proper resident, that I did my research with John Marshall.
So for our listeners who may or may not know about John Marshall, run down some of John's accomplishments. You and I both share friendships with John.
Yes, yeah.
He's one of the great giants in our field, but he's made so many enormous contributions. But just talk about John a little bit. He's so inspirational to all of us.
Yeah, so John is unusual in that he had a very, so I described a working class background. He came from an even more working class background. He used to have to go to slipper baths, which those who to have baths as a child, and really worked his way up through education and intellect. He basically is unusual in being a professor of ophthalmology that's not an ophthalmologist, and that's rankled a few people over the years, but essentially did it through just being a really good scientist and a good communicator. So pretty much everybody who in John's extended career wanted to have someone present at their conference would be calling John, because he's just a great presenter. His work started with laser, as far as I know. It was to do with the retinal pigment epithelium. He was involved in a lot of work to do with the underlying mechanisms of age-related macular degeneration. When I was at St. Thomas's, his lab was doing a lot on Bruch's membrane and its permeability and the collection of lipids within it. So essentially, and then the question about things like PEDs and how they happen and what the mechanism is. So John's been involved in that, but he's equally well known because of the laser connection for excimer laser, the treatment of the cornea, and had the patent on that for several years, working at Summit Technology, working with them. He's an unusual English ophthalmology professor because he's not an ophthalmologist, but also because he understands industry and understood all of that without being avaricious. He's actually understood the whole the market and how it works and what good products are and what good companies are, and has been involved in building a lot of those too.
Well, John, to me, is remarkable not only because of his command of physics, which is, I think, possibly unsurpassed in ophthalmology, but because he's made so many contributions to humanity by combining his in-depth understanding of the eye and physiology and physics. So the scanning laser ophthalmoscope, retinal recognition devices.
I was involved in some of the stuff to do with automatic recognition with a guy called Greg Heacock for identifying people.
Right.
I have a feeling that's been used in ways that might not be as obvious as we were.
Right.
Yeah.
It's gotten a bit nefarious, but he's just, and then the hydrophilicity of Bruch's membrane and the transmission of water across Bruch's and other metabolites and just enormous contributions to the field. But also he has trained a cadre of magnificent contributors, you included, and he's a personally accessible, lovely man, but he's also just a giant intellect. And so talk to us a little bit about what it was like. Were you intimidated at first by John, and what was it like? Or did he brings you over for tea or whatever it is, and all of a sudden you're right inside the circle of trust?
No, it wasn't that. I think what was really interesting is that, and I've talked to him about it and others since, is that he had this and it's not a problem now for it to be revealed, but he had an sort of interviewing or selection technique that had two stages, where you'd go and see him and talk about doing some work and doing some research, and he'd give you some pointers, say, maybe you should go and look at this. And with me, it was all, let's look at lots of lasers. So I read loads of papers on laser pathology of laser wounds and stuff in the eye. And then I went back to him and thinking we were going to discuss that. And he didn't, and he talked about something else. And then said, I think you should go and look at this. So I went away and did it, and then I got back, and then we did go on and do some research with that. But I think what he did was he had this selection process where if you showed that you would dive into it, not get knocked back by the fact that it wasn't what we're going to do, and then worked hard again, that he'd select you and that would work well. So it was a two-stage process. What I found best about working with him was that he discussed, but it was a very Socratic, asking questions way of working, where learning for me, where he would ask questions that would lead to the next me answering questions and then going, oh, actually we should do so-and-so. And that was really important. And then the most important part was learning to write papers, etc. Because essentially he did this thing where, this is before laptops and stuff, and people, what he did was he used to get you to print out 2 copies of what your paper or the chapter you've written, double spaced, and you'd sit side by side he would have his copy and I would have mine, and then I had to read out what I'd written. And and the idea is that we would correct it together, and by reading it out, it's like, oh, that doesn't make sense. What I'm trying to say is, so actually without him saying very much at all, just the whole process got me to think more clearly about how I wrote and correcting it, and then hopefully being much clearer in the message you're trying to get across. And that was really cool. It was that reading out aloud, which I still do now. So if I've written something, I will read it out aloud to myself to see if it makes sense. And then when I was with him, it would be like, well, does that actually say what I'm trying to say? So it was a lot of writing technique that I learned from him.
Spectacular. I really envy you your time with John. I've spent a fair amount of time with him and never trained directly under him, but I'm a great, great admirer of him. So you finished your research with John. That was presumably your MD thesis.
Yep.
And what was the specific thesis?
So it was the interpretation of OCT images of the macula. And that was, I actually was examined in 2001 and published some work on that in 99 and earlier on a few papers on that. So it was on the interpretation of macular images.
That was just as OCT was coming into ubiquity, even before, really.
It was before. It was still at the point where people were saying, there were retina specialists saying, I don't need this. I can look in with my ruby lens or
my
contact lens
right,
and see all of this, which they couldn't. But at the same time, the actual specifics, the really fine details of the scans weren't there. They looked as if they were, but they weren't. And so we did things like, John and I did things where we got a human and bovine cadaveric retina in discs that we'd cut out, and then got an excimer laser and lasered concentric circles so that you effectively got like an amphitheater leaning down. So if you were looking at specific layers of the retina, and that's what the signal was, well then as you go down, you should lose those signals. That's not what happened. So the surface gave you a high signal, the retinal pigment epithelium gave you a high signal, and however much you cut down, that's what you saw, the two bright lines. And so that was, we thought, was quite an important finding, that the layers that you saw, and this is a long time ago, most people haven't seen these images. This is the original OCT that came out of Zeiss. I think it was called the OCT 2000. I think it was that. People were seeing these lines thinking they were seeing anatomy, and it wasn't, histology. It's obviously got much, much better since then, but there was a lot of overinterpretation that was happening at the time. And I think that what we did was to demonstrate that you need to think about the optics of the OCT and the fact that it's an optical image rather than this is pseudohistology, which is how people were beginning to think of it. It's closer to histology now, but it's still important to think about the optics like we see in geographic atrophy, for example.
Absolutely fascinating. And then where did you go from there? You finished your MD, and where did you continue your training? So
I ended up being in the North Thames registrar rotation, which is, for everybody else, is the Moorfields rotation. So I spent 4 years, of which 2 were at Moorfields, and the other 2 were at other hospitals. One at Charing Cross, and the other one was called Whipps Cross, which was cool. That was really good. And the bits that I remember were in the non-Moorfields hospitals getting to do lots, because as you know, as someone who's gone to the UK to be trained, the volume of work at the time was huge. Lots of Australians go there, a fair number of Americans used to go there. So we got lots of training and lots of experience. And then when I got to Moorfields, it was just fantastic, because at that time, literally almost pretty much every consultant attending was at the top of the international game at the time, which was great, because you'd go, I remember being in the emergency department, the eye emergency department, you'd go and have a patient, and you just walk to a clinic where there was Richard Collin, John Lee, Bob Cooling, there were all these Peter Lever, there was these big names and people who not just knew what they were doing, but they wrote the textbooks, which was cool. And that was just really, really affirming, and it was a great learning opportunity.
And you went from Moorfields to Australia, and then back to England, or again, and then back to Australia. So you've worked in both systems.
Yeah.
Compare and contrast. I mean, obviously, you're a product of the NHS, possibly literally.
I am literally a product of the NHS.
And so you've got a great proclivity and great affection and nostalgia for it.
Yeah.
But you did move to Australia. And tell us a little bit about the Australian healthcare system. For our international listeners, we've had guests from all over the world, none from Australia yet. So people don't really understand. Explain what the gap is and what the mix of public and private commitment is for the typical Australian retinal surgeon.
Okay. So the system in Australia is a bit of a hybrid between the US system and the UK system. Essentially, the government will pay a certain amount for a procedure to be done, for example, for a vitrectomy. And they'll pay this many dollars, and then it effectively doesn't really care whether that's done in the public or private sector. If it's done in the public sector, it covers everything. If it's done in the private sector, then that can be topped up. It costs more there. So that can be topped up by health insurance. And then there's a potential for the surgeon to charge literally as much as they like on top of that. So there's a gap. These aren't real numbers, but if a vitrectomy was $1,000 from Medicare, which is the system that's available for everybody irrespective of age, then if the fee is that, and the insurance company will add an extra $800 to that $1,800, the doctor can charge whatever they like, up to 2.5, 3, 4, 5, 6,000, whatever. So there's a gap at the top, and then there's insurance and Medicare. As a result of that, it takes some pressure off the public system, and that's the idea. Is it's a mixture of public and private, where many patients can choose one or the other. I'm not sure about the exact numbers. I think about 40%, maybe higher, of people in Australia have private health insurance, which covers that extra bit on top of what the government pays. And so as a result of that, there's fewer people, and those who would be essentially Medicaid or normal Medicare patients in the US who go into the public system. But if they choose to, they can shift over and either pay with cash the difference or with their insurance. So it was difficult for me to get used to start with, because I'd been in the NHS where I just got paid a flat salary, and then I moved to a system that had a private thing where it was fee for service. So I struggled with that for a while, and I've developed my own ways of dealing with that. But once you do, and once it's like what everybody expects, it seems to work pretty well. And I think that there's a trend in the UK for there's a political trend to move towards that system as a way to take pressure off the NHS. I don't know if it will happen or not, but
so basically, the individual provider, the surgeon or the doc, determines their own market, what the market will bear for their services.
Yes.
And the gap can change from day to day, patient to patient.
So what tends to happen is they set their prices. This is what I'm worth, or my services are worth. And if that's as much as Medicare pays, then that's it, and the patient gets the service for free, and etc. It can go up higher than that. So they choose. And what often...
Sorry for interrupting. So do docs phrase it as I'm worth a multiple of government fees, or do they phrase it as I'm worth $5,000 more?
I'm worth X number of dollars.
More than whatever the fee is?
I think the more appropriate way to say is that the doctors decide that this is a reasonable fee for what they do.
And then...
In total.
In total.
And
great.
If some of that small amount or large amount is covered by Medicare, that's not up to me because it's not kept up with inflation. So I think many years ago, before I even got to Australia, Medicare would have been close to that, or if not the whole thing. But because the Medicare fees have not gone up in line with inflation, effectively the proportion has dropped that Medicare would pay of the market price, if you want to call it that. So the gap has increased over time, part of which is covered by insurance, but there's still a part that's not.
So just to be clear, your father worked in the London Underground at Heathrow.
Yeah.
And used to say into the microphone, mind the gap.
He didn't say that, but yeah, I know what you mean.
Right. And now you've got patients and they have to mind the gap because you might charge more than.
So, yes.
My very feeble attempt at humor.
Yeah, it's fallen flat.
Right.
Basically, so when you say you, if you're talking about me, I have a slightly different
I know
way.
you're different. We'll get to that in a minute.
But one...
I'm generalizing.
One, as in an
Aussie.
Australian retina specialist, will charge what one thinks is the appropriate amount for one service.
Right. Now, Australian retina is particularly clever. There are a cadre of huge names in Australia, and we'll, I promise the audience, come to interviewing the majority of them. You happen to be here this week, and so I'm lucky to have you as our first penultimate or ultimate Australian representative. And so besides the gap, and correct me if I'm wrong on this, the powers that be, whether it's Ransco or whoever it is, the Royal Australian New Zealand, do they modify or moderate how many retina specialists can come into a certain area?
No, they don't actively do that, but I don't believe that the numbers are increasing as rapidly as probably would match the population. And
I have a recollection that certain people can only move into an area based on the number of the population there and the need.
So if you're an Australian trained doctor, then you can work wherever you want. And there's a thing called provider number, which is equivalent to an NPI, I think it's called here in the US, that you just get wherever you want to be. If you're an overseas trained graduate, then that's restricted to areas of workforce shortage.
Got it.
And those are generally outside cities, but there can be sort of pockets that count as within a city that are areas of workforce shortage, and there you can get a provider number.
How long did it, you were lucky you did your fellowship there and they got to know your super strong work ethic, but how long did it take to assimilate into Australian medical community when you moved back in? Were you immediately accepted, or did you find, I know when I moved to England, there was a lot of anti-Americanism.
That's still there.
Right, well, probably appropriate in some forms, but the point is, I always said, you hate me because American medicine is better. And they came to understand that over time, of course, falling flat again. But the point is, one faces sort of an incumbency, not in my backyard type of feeling. How long did it take you to feel like you were assimilated into, as a quote unquote foreigner?
Yeah, I don't think it was to do with being a foreigner. I think it's because for a whole series of reasons, I wanted to, but couldn't end up working in the public system. Therefore, couldn't be training and teaching, and was working purely privately. I think it was a function of being out in a private network that meant that I wasn't immediately part of the whole system.
Right. To me, looking at it from afar, at the beginning, they probably thought they were punishing you, and in the end, they were envying you. And so, but let's shift gears away from the politics and the medical systems, and talk a little bit about your inner drive to innovate. You now are one of the leaders in applying artificial intelligence, or AI, to the physics of OCT, and you've come forward with this wonderful platform that helps physicians consistently interpret OCTs and therefore benefit patients. What lit the fire for you, besides your drive to always question why we do things and how we do things? What lit the fire for you to bring AI into
There
retina?
was that question of, do I need to have, can others read OCTs as well as I can? And that was answered by having staff that I taught, because I wasn't working in the public system. I had my, they're called the orthoptists in Australia, do the function of scribes and techs, both together. So they were the only people I had an opportunity to teach, so I did. And it became pretty obvious very early on that they could learn how to interpret scans, and they knew what decisions I was going to make, particularly with respect to intravitreal injections. They knew what I was going to do and how I was going to do it, and more importantly, they knew what my colleague was going to do, which was different. So it was pretty clear to me that it's a very protocol-driven environment. So I don't know if I was driven more by just curiosity of whether we could write software that could do that because it would be more efficient, or because it's possible. But that's what sort of led to...
Well, you and I both know you did it because you wanted to help more patients.
Yeah, I think so. And this harks back to the NHS thing. So my underlying thing is about getting the highest level of care to the most people, and ultimately it'll be at the least cost to society, which is about getting the same level of care as you or your mother would get.
Anywhere.
And that's really what...
We call that democratizing outcomes.
Yeah, I think that's absolutely it. And I think depending on which country you're in, you're going to have different approaches. And in the US, it's very much a commercial and clinico-commercial environment where we need to do things in a certain way. Down the track, in the NHS, which I really want it to go there sometime, because for obvious reasons, in the NHS or in parts of India, and I've been talking to people in parts of India in large groups there about potentially putting the software there, where it could end up doing exactly what you're talking about, getting that democratizing of outcomes.
When people ask me about what your software does, I tell the story of when I was a fellow. One of the co-fellows was a genius called Frank Holtz, and Frank, had an incredible penchant for interpreting, at the time, fluoresceins. It was pre-OCT in those days. And we would sit around and the light table with Alan Bird and all of the fellows, and it was a giant conference table with the light underneath it, and we would interpret those fluoresceins. And Frank was probably the most consistent reader of fluoresceins. The Australian contingent in those days was Alex Harper, and later Robin Geimer, and the American contingent was me and Jack Wells, John Robleski, Bob Kim, who's been in industry for a long time, and many, many more who I'm just forgetting right now. Swiss was Thomas Wolfsberger, great cohort of fellows, and we would disagree about fluoresceins, and then we would look at them, and Frank got sneaky, and he would show us the same case a little bit later, and then he realized we had a different opinion than our own previous opinion earlier that day or earlier that week.
Was that related to lunch, or?
It was either related to lunch, probably not too much to alcohol, really just internal inconsistency.
Yeah.
And he wrote papers about inter and intra interpreter variability.
Yeah.
And so not only is AMD a grab bag of diagnoses, most likely, with lots and lots of diseases and lots of forms and speeds of progression and everything else, and risk factors and outcomes and so on, but a lot of interpreter variability, both between physicians who are like-minded and trained under the same professor, and even within the same physician, different times. And so when I think about what you've done, is you can set the parameters of the network to interpret the OCT per the physician's criteria, and then say, okay, there is subretinal fluid, or there is not subretinal fluid, or there is intraretinal fluid, or there is not intraretinal fluid, or there is sub-RPE fluid, and these findings, and many, many more, of course, and these findings then lead to an algorithm which the provider has determined will lead to a re-injection or a new injection, and keeps that person consistent. So it's a physician
driven and controlled piece of software that combines the objective components of measuring biomarkers, but allows them to feed into personalized decision trees. And that's essentially what it is. So that's what our software does.
Right.
And as a result of that, it means it's consistent for each doctor, but doesn't necessarily mean it's consistent between doctors. Because that's what the nature of medicine is, because it's like no one is going to agree. So I think we've allowed that flexibility to allow doctors to do things the way they wish to.
Right. So you're not imparting or imposing a dictum on retina and saying this is how you should treat a patient.
No, because I don't know any doctor of any sort, let alone self-important retina specialists like you and me, who would allow a piece of software in 2025 to tell them what to do. I think there might come a time down the track where that is acceptable if you've shown and presented data to show that these are the reasons why the explainability part of AI, and then the validation of it with some kind of studies that's appropriate. Down the track, people will. I mean, I like to think of it as similar to, we drove here today, and I'm sure you've got lane assist and adaptive cruise control, so you don't go too far into the car in front.
It's very kind of you to say, since we were bouncing off the hedges, but...
So with that in place, that's how things are right now. And that's what we're doing with Macuject. We're allowing people, we're highlighting when people, with this decision support software for intravitreal injections at the moment, but it'll expand. What we're highlighting for people is actually, you yourself, if you had all the time in the world and were sitting on your shoulder advising yourself, might say, well, what about this? And have you noticed so-and-so? That kind of stuff is where we are right now. Whether it leads on to a semi-autonomous or almost not quite Waymo level, but close to that, I don't know. And that's where I think things might go. But I think what the software does will go along with society and where we all go.
Right. So let's just take a step back for a second. So I've been lucky in my career. I've had 3 to 5 fellows looking at every scan. They call me out. They're trying to stump the prof. And they find things that I wouldn't have found. They keep me honest, and they're questioning me all the time. This is essentially an automated fellow that, in a way, that looks at the scans and looks at every single scan and knows my criteria. So,
well, it's the AI, the ML, machine learning component, finds stuff, okay, and will say, have a look at this. You're still in charge. You're the retina specialist that has the experience, and, for example, will know that it's macular telangiectasia, not leaky fluid. You'll know that this is an outer retinal tubulation, not fluid leak. You'll know all of this stuff, and but the machine's just saying, do you want to have a look at this and see what you think? So it's not quite the fellow telling you this is what it is. It's saying, I've noticed something, you have a look.
Well, that's what my fellows would do. What is this? Well, that's an outer retinal tubulation.
You need better fellows.
Well, my fellows are the best.
You need fellows that are going to say, I think it's this.
Well, they do.
Do you agree or not?
I would put my fellows up against anyone.
Okay,
But so let's go to when you first wrote these networks and developed this stuff. It took innumerable amount of learning from the machine, but now the machine's learned it. You tried it, I'm sure, in your office, in your clinic. So what were the findings? Did your patients have better outcomes? Did you find, tell us about, like, besides the efficiency, which I'm sure is great, I know that before I come in the room, if my nurse or technician can say to the patient, look, you've had your scan, you've got these 3 findings, Dr. Schwartz is going to tell you need an injection. Do you want me to get it ready for you now before he gets here and can have everything ready, and I come in and validate it and go ahead and give the injection? I'm sure it's loads more efficient. I'm not that interested in the efficiency. That's fantastic. Congratulations. Patient-facing, that's great. But let's talk about the safety, efficacy, and outcomes. Did you see anything different in your patient population?
So I was like any self-respecting, over self-respecting retina specialist, there was an American retina specialist I spoke to who asked me, what are your results like with this a few years ago? And I had to say, oh, I haven't actually looked at them. So I went back and looked at my results with Macuject compared with without Macuject, and there was a p less than 0.05, statistically significantly better visual outcome with Macuject.
This is in across all of your wet AMD patients?
All my wet AMD patients. And that's in spite of, and you may not know this, but Australia has we have no restriction whatsoever on which drugs we use and how often. So for example, Eylea HD, we can use every 4 weeks forever if we want to. So there's no restriction on that. We don't have to, there's no step therapy. We just start with whichever drug we think is best. And
how much Avastin use is there in Australia?
Close to zero. So there might be a few people, but I don't know anyone who uses Avastin. And this is before the controversies about compounding, for example. So we use whichever drug we like in pretty much any way we like, as long as it's more than 28 days between injections, irrespective of the label and what was done in the studies. So, and most of us do treat and extend, and we extend by 2 weeks. And most of us, in spite of certain papers, try and keep a very dry retina and don't accept leak, and will shorten intervals regularly. So as a result of that, we have a very high injection rate in Australia. So I think the most recent figures I saw for the US were on average about 5.6 per year for wet AMD. And we know from Tom Chula's papers that if you go from 3 to 10, you actually get a linear increase. Admittedly, that was with the original 2 anti-VEGFs, so the frequency might be lower now, but I don't believe that you're necessarily quite there. Whereas in Australia,
we're under-treating.
I think that's a reasonable conclusion to draw.
I totally agree.
In Australia, it's something like 7.5, 7.8 per patient. And I was doing that frequency.
Oh, I refer to that as the injection index, the number of injections over the last 12 months.
Yeah, sure. So that's where most of us are. So I found that statistical improvement was only 3 letters, but it was real, and that was with the patients I was treating for the 2 years before I had the software, and the 2 years that I had it for that time. So that's one definite improvement.
How many patients was that, you think?
I'm responsible for about 8,000 injections a year. So it was probably over about 30,000 injections, 25, 30,000. I can't remember the numbers.
Non-trivial.
No, it's not trivial. So then the other thing, when I've used it and other doctors have used the software, and there's not that many of us who have in Australia, because we've done the development of the clinical component there, that actually it's pretty common that we'll find something in the other eye or see some fluid that's very early, that if we'd scrolled through carefully every scan, we would always find. I find that I probably only scroll through the central third most of the time and do it reasonably quickly. But now that I've got the software, it just shows me an overlay saying there's something here. I can click straight on it and have a look. So it's got a high sensitivity, and we find these small abnormalities.
Early detection of fellow eye lesions.
Fellow eye and the same eye. That's what I'm experiencing right now, and it's not just me, but the other doctors have used it. So what we found was that, and also because there's a nudge towards sticking to your own protocol. There's only 3%, but with the ceiling effect of doing that high index, there were 3% more injections done with the software compared with that without for one other doctor. And that is, when you talk to them, is actually very much about picking up abnormalities.
I have a question for you. This is sort of a mercenary question, but does it take you more time to inject a patient or more time to decide not to inject a patient?
Well, I think the latter, definitely. I mean, we apply in Australia, and I was at a meeting this last weekend, just gone, where it's pretty definite that we pretty much all apply a strict treat and extend. So Mark Gillies mentioned that there was some, he's got, because with his fight retinal blindness product, his
database.
In Australia, 96% of patient visits are associated with an injection. So it's definite treat and extend. It's not any form of PRA.
Well, Mark is brilliant, and his work with that database and his other contributions have not just changed, I think, care in Australia, but impacted global care. He's a real giant in our field and a wonderful human. So when we go back to this AI that you've written, and you starting to look at it in various clinics, what are the additional benefits? So we're seeing not decision support for physicians, but rather guided image interpretation that's customized to the physician, and then driving the physician to look at a particular image within certain criteria that physician has set. And then what are some of the other benefits of your system?
So the question about using the phrase decision support or assistance, it's difficult.
It's a bad word, and I apologize.
Yeah, no, it's a difficult one,
it's not really decision support, though, is it?
Well, it isn't. So it's a device. It's a medical device. Software is a medical device, and by our understanding at present, and we're about to discuss this with the FDA soon, is that only the image analysis and the measurement, the segmentation and measurement of the abnormalities in the OCT scans is the medical device. The rest of it, because it's totally driven, totally overseen, and totally overridable by the doctors, is whether you want to use the term decision support or assistance or assistive, it doesn't really matter. It's not a medical device.
It's not making a decision based on the data. What it's really doing is taking the data and pointing the physician towards the data so that they don't miss something in the data.
I think that's really, like I said, it's important, but I haven't quite sorted out. I'm going to wait for the FDA to tell me how to think about it. We're going to them with stuff, and we'll find out more from what they say in terms of how we should describe it and what's acceptable and what's not. The FDA is really good because at the moment it's well ahead of the other regulatory authorities in how to look at AI and machine learning products. In fact, there's something that just came out that I need to read, and literally came out yesterday, I think.
Guidance.
So they're very good at that, and it's important to make sure that we don't push away from that or stick. I think we need to stick within that lane.
We like to think we're patient first here in the United States, and business and efficiency second.
Yeah.
And so we do tend to be inefficient in a lot of ways. But
so I mean, answering your, sorry, I got on a sidetrack there. Answering your question, there's actually, in addition to the commercial benefits of increased workflow efficiency, which are real, I'm 50% more effective. I'm doing a lot of injections. There's also a component in our current software which deals with step therapy, which is a significant problem for patients and providers in terms of getting the best drugs to the patients.
So for our international audience, we have significant listeners internationally who won't know what step therapy is. Right. Just explain it from your perspective, an outsider looking in to our admittedly very broken American system. It's far from perfect. We've got multiple ways for patients to have. In
spite of what you were telling the people at Moorfields.
Right. Yeah. Sarcastically. We've got multiple ways for patients to be covered, and unfortunately multiple ways for patients not to have their health care covered. Yeah. So we have loads of uninsured patients. We've got loads of patients who are partially covered or only covered for certain things, and the decision for which drug is best for the patient is often not in the physician's hands or the patient's hands. It's in the payer's hands. Yeah. And it's expensive here.
So, my understanding, I've spent the last couple of years trying to understand the American healthcare system.
Good luck.
Within ophthalmology, within retina, and I think I've got an idea, but I'm sure, it's tip of iceberg material. Essentially,
so what is step therapy from the outside looking in?
My understanding of step therapy is that the insurers not the government, but the insurers who top up and do extra bits, mandate to retina specialists that they need to start with Avastin, bevacizumab, which is off-label, but they mandate it, and it's a protocol in which, and it varies between insurers and between insurance plans, where the doctors are required to use Avastin once or twice or even more, and they have to demonstrate that there's an inadequate response to the treatment. And so it's a fail-first approach. It's not just used in ophthalmology, oncology and other specialties have it too, I understand. So they're required to fail treatment with Avastin before they can move on to another on-label drug.
Presumably more effective, but also much more expensive.
Much more expensive.
And the truth is, the CAT trials demonstrated really beautiful equivalence or non-inferiority across the original on-label and off-label anti-VEGF agents. And so there's an argument to be made for it. And forgetting about the step therapy efficiencies, because what your software presumably does is clearly demonstrates in an automatic way early failure.
Yeah, it highlights early failure and allows a retina specialist to consider, or enables them to, at the point of care, rather than their staff beforehand or later, determining that actually this might be a point at which the insurer would accept prior authorization next time of using a branded drug.
So you're putting a tool in the physician's hands to document findings in a much more efficient way and advocate for their patients, which I like. Now, and I think the insurers will like too, because they just want the documentation.
Yeah.
What about, do you still have, I remember in an early version that I looked at of your software, you had a beautiful which drug, the duration, the agent, the vision.
Yeah. So essentially what the real at the coalface problem that we're dealing with is the reason for the slowness or the inefficiency or the undertreatment, which is that in order to make the best informed decision on that day for that eye, and
honestly, in that moment,
ideally you have all the information. You want to know which drugs have been tried in the past, how often, what's the longest interval with the treat and extend approach that each drug has been associated with, where it's controlled the fluid, what we call the fluid-free interval. You want to know what that is for each drug, so that today, for example, if I'm seeing a patient and I've extended them to 10 weeks and it's failed with drug C, I want to look back and see, well, how far did drug B and drug A get? Did they get to 10 weeks? And if it was 10 weeks, was it better control than it is today? And then I can make a decision about where to go back and whether to switch or not.
Now, when you see that, in that very instance, do you feel that it's only the agent, or do you look at the totality of the patient and say, well, maybe their blood pressure's changed, or their coagulopathy has changed, or their medicines have changed? Are you interfacing, or is that just an unrealistic professorial outlook?
I think that's an unrealistic professorial outlook, and also we don't know. No one knows that. So I think as time goes by and we have these large time series data for a large number of patients, especially if we get additional data from the electronic health records, that there's a potential for predictive analytics and an ability to, or if it, that we talked about this before, if there's a semi-autonomous prescriptive approach, which I can't see happening within I think it's at least 3-4 years, maybe longer, a semi-autonomous prescriptive approach where, and it's only when society's ready for it, like they are for Waymo's and now in Los Angeles and previously in San Francisco only and Austin. If we're ready for it, when that time comes, there's an opportunity for people to accept a black box. Having said that, I think that there would need to be studies down the track where a black box is tested over time, and I'm not sure who would do that study, what the design would be, but we need evidence that these things work. And I think one of the issues with generative AI, for example, and I'm not talking about generative here in this sense, the semi-autonomous thing's going to be done differently. But with generative AI, this confabulation component is so risky that we couldn't possibly take that risk without doing formal studies. I think that's what's going to have to happen down the track. I don't really know exactly what they're going to look like, these studies, but they will have to happen, I'm sure.
Well, I'm completely enamored with what you're doing, and full disclosure, I've joined your board, and I'm really, really excited about the benefits that you're bringing to patients and to providers. As we start to wrap up here, tell me what scares you about AI.
The confabulation component.
The hallucinations.
Yeah, I think it's confabulation, not hallucination, but that's
whatever.
different.
It's just the term that we're used to here.
Yeah. Everyone's saying hallucinate. I think that's part of it. We all use ChatGPT and stuff to do some research stuff, and even when you ask it for, give me the citations, when you click on them and you look at them, it's like, oh, this doesn't actually say what it said. You know, like when you see papers and they've got references and you look at the reference, no, that's not actually the appropriate reference for that part. That's one part. So I think especially if we end up using AI actively to guide decisions, which is not what we're doing now. We're not doing that. Where if we use it to say, oh, you should probably do this, that's where you just have to be as sure as possible that's not an issue. The other part is obviously in this room we've got a couple of different ethnicities. Yes, we're probably actually racially closer than I am to an African American or to someone from an Indigenous Australian person, but you and I might be very different in terms of some subtleties that might not be relevant to segmentation of an OCT, but may well be relevant to predictive components. So how that bias gets addressed, I think I'm concerned about.
I am too. Now, was there one patient or one experience that provoked you to start studying AI and how it applies to this, or was it the John Marshall experience way back in the day?
To be honest, it was neither of those. It was absolutely to do with, the people who I've trained who aren't doctors, who know what I'm going to do, know what to do next. And that had two components. One was understanding the decision tree, which is part it's the treatment regimen, which is and doing that in the real world. That's the most difficult part of what we've done, is actually putting real world decision making into code so it just works. You've talked about the AI throughout this and brought that up, and that everyone does. But the most significant part of what we're doing is that real world decision making. So for example, what happens if a person comes early for an appointment or late? They want both eyes together or they don't want both eyes together. How do you bring that into the decision making and the planning of the next treatments? That's all covered by our software. So that's what the people who worked for me knew how to do. So we thought, well, let's put that into code, and it took literally 18 months of lots of injections, probably about 10 to 15,000 injections of iterating and getting those protocols, those decision trees right so they just work. That's the key part.
And so that's what motivated you.
That's what motivated me first, because I thought it was going to be really simple. I thought, okay, you boil it down, you've got plus 2 weeks, minus 2 weeks, which is treat and extend. Is there a black space on a scan or is there not? I thought it was going to be easy, but actually I was probably in retrospect highly dismissive of our skills, and now I'm recognizing that actually the decisions we make as we go are actually really complex. But we've reproduced most of them, not all of them. There's
but you're using the word decisions. Do you mean observations that we make?
So the observations, but also the decisions. There's a combination of the two. And the decisions are based on findings and presenting those findings in a certain way and allowing the doctors to configure the decision tree to their own preferences so that the recommendations or the output of the software is, hey, this is what you might suggest to yourself. Check, see what you think.
Do you feel that this software will have a role in teaching trainees as well?
I think there's a reasonable chance where if they're, I think the way it would work, and going back to what we were saying before about your fellows, there was a guy I used to work for in St. Thomas called John Schilling, who did not want me to go to him and present all the findings. He said, tell me what the findings are, but you have to write down what you would suggest, what you think the diagnosis is and the plan. And then if he agreed, he would just write, I agree, okay? In the same way, that's what this does. It says, here's what seems to be the way that you would decide this, or the decision that you would make. And then you as the doctor have to go through and go, yes, yes, no, 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 yes, or override. So it actually is doing the job of, now I'm taking it back and agreeing with you, doing the job of the fellow to say, here's some findings, have a look, see what you check those. Here's my logic for why I think you're going to say do this, but you the attending, you the retina specialist are in charge, and it's all in your control. That's
well, it may be prescient because my fellows were all smarter than me, and they were almost always right.
Yeah.
But not always. And I spent a lot of time checking their work.
Yeah.
But their thinking was usually pretty good.
And they're not always as important.
And I learned a lot from them.
No, of course you did. But and that's what hopefully I think that's what you're getting at, is it'll highlight things, and with the residents or fellows, they'll be looking at it going, yeah, actually I agree, that fits, or oh no, I don't agree. But that's what they need to be learning to do.
So how is this transition to becoming so passionate about something that's sort of ophthalmology adjacent, which is this programming and AI and physics? How's it affected you personally? Are you even more excited and passionate than you ever thought you'd be at this stage in your career?
Yeah, absolutely. So I stopped operating just under 2 years ago, stopped doing vitrectomies and cataract surgery in Australia, like a UK retina surgeons do cataracts too. So basically, I stopped operating and didn't really miss it because it was no longer, including because of Avastin and anti-VEGFs prior to DLAMs, it just meant that I wasn't doing the really interesting, complex delaminations, the diabetics, because there were fewer of them. And when they did happen, because I'd got good or pretty good, I could just do them. But they were my favorite. They were my favorite operations because it was non-linear surgery. You started off, you had principles, you tried something, didn't work, you tried something else, didn't work, and then you do this and you attack it from different directions. I'd begun to lose that in clinical ophthalmology, but running a startup is absolutely the same thing, but potentially an extra order of magnitude because you've got no control of what's around you. So I've described it as doing a combined tractional and regmatogenous diabetic detachment with a dense vitreous hemorrhage and significant cataract. You start and you're just working through and when it comes together, it's fantastic, but a lot of the time it doesn't, and you have to try and do something else. It's that sort of like totally iterative, reactive kind of thing that I'm loving. And it's a total challenge because the reason I was finding it not as challenging, and the reason I did VR was because it was difficult. It was the bit I wanted to do what I perceived as being the most difficult type of surgery in ophthalmology. And I did that, and I enjoyed it. But then when it wasn't as challenging, I wanted to find something else. And so in retrospect, what I've found is actually something that's way more challenging, and very occasionally I think, maybe I should have just stuck to ophthalmology.
Well, it's scary, and we've talked to other CEOs, and they've expressed the same fear of flying, but it's the scary things in life that often turn out to be the best decisions and the most impactful, and we're counting on you to make a huge impact, and we're so grateful for the time and the conversation here at Retina Rounds, and wish you all the best of luck, and hope that our audience has found it as captivating and as infectiously enthusiastic as as you've been with us today. So
Yeah, thank you. Thanks.
Devinder, thank you
Steve.
very much for your time. Really, congratulations and best of luck, and spot on with your efforts to improve the lives of our patients.
Great. Thank you. Thanks very much, Steve.
What a
Thank you.
pleasure.
Thanks.
If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.